Hello, my name is Marlon Pragnell. I'm Vice President of Research and Science at the American Diabetes Association. And I'd like to welcome you to Spotlight the Science, where each month we interview amazing researchers that ADA is funding and learn all about the exciting work they're doing. So it's my pleasure today to speak with Dr. Josh Denson, who is Assistant Professor at Tulane University School of Medicine in New Orleans. He's a physician scientist whose research interests around patient outcomes in the ICU. And he's actually on the front lines of the COVID pandemic. And he specializes in the care and research of patients with acute respiratory failure and sepsis. So obviously this is very critical in this period of the COVID-19 pandemic. His most recent studies investigate the link between metabolic determinants of health, which is metabolic syndrome, and acute respiratory distress syndrome, ARDS, where he's studying to how better identify patients who may respond to precision medicine-based treatments. He's also PI for several clinical trials in the ICU and serves as the Director of Medical Intensive Care for Tulane. Welcome, Dr. Denson.
Yeah, thank you, Marlon, for having me on. I appreciate the opportunity, and ADA has been wonderful in helping me figure out what I want to learn about and try to help other people. So thank you.
That's great. We're thrilled to be able to fund brilliant researchers, and happy that you are part of the number among the researchers that we funded to do COVID research in diabetes and metabolic syndrome. Can you give us a little overview of the work you've been doing?
Yeah, absolutely. So, as you kind of said in a very nice intro, I'm an ICU doctor, and I. Starting the beginning of 2020, I was very much inundated with COVID-19 and respiratory failure. And, I ended up putting our first patient here in Louisiana on a ventilator before we even were under lockdown. I was quarantined the week before we went under lockdown, So I was very much involved in it. And so having it as part of my life, so much so there in March 2020, I started noticing a certain type of patient, right? That really got the most sick from COVID-19. And I thought it was very unusual for what I often see in the ICU. We noticed these patients that tended to end up on the ventilator in what's called ARDS, or acute respiratory distress syndrome, had a certain set of characteristics. They weren't necessarily the classic patient with really severe disease, but they often were obese, had mild diabetes or even pre-diabetes, had high blood pressure and had a history of high cholesterol, and really fit this type of picture of metabolic syndrome, which not too different from the other type of syndrome I talked about, ARDS, is somewhat of a hard definition to assign to somebody. And it's just a constellation of risk factors and is a sign of poor metabolic health. And so that led us to ask the question, is these set of risk factors, are they increasing the risk from COVID-19? And that's what led to this proposal and some of the research that we've been working on for the past couple of years now to show this association.
Wow, really interesting. So you are there at the very beginning of the pandemic. It must have been quite a scary situation there, realizing this huge kind of wave of potential infections that would be happening.
Oh yeah, absolutely. I mean, I have two kids, and it's one thing if you sign up to go to war across the world, which my grandfather did, but it wasn't really expected. And I think it's one thing to put ourselves at risk, but having to put our family and loved ones at risk every day definitely was stressful. But I don't consider it any different than someone working in the grocery store, gas station, a nurse, obviously, or anyone that's working in any sort of a health setting. The risk was similar, if not greater, for them than myself. So yeah, it was scary, but I don't think it was any scarier than what other people faced that had to show up for work every day anyway.
Yeah. But being in the ICU and seeing patients on a regular basis and so on, how did you protect your family?
That's I don't know if you want all the details, but we had a relatively small house. I live in New Orleans, and the house actually has like an alley that you can walk next to it. And so I ended up sleeping in a back room on an air mattress for at least a few months while we were very busy in the ICU, just until we figure out just how contagious this is. If it's like the flu versus Ebola. Ebola is very much transmitted by contact versus the flu and COVID now that we know is more transmitted by breathing and it's in the air versus touching things. But in the beginning, I would basically wear scrubs every day and change clothes outside this alleyway, keep everything outside, and try to immediately wash anything I could, including keeping shoes, and then basically living in the back bedroom for months. And so my wife and family and other friends thought I was crazy in the beginning because I'm like exposed to this first patient, and I'm back in the bedroom. I'm not making contact with anybody, and they all thought I was crazy because I'm basically watching the news all the time and just separated from everybody. So it was a wild first few weeks there, and then I was in and out of the hospital, and everyone has a story like this. You can ask any ICU doctor or hospital worker that they have something relevant, a similar story, but you had to kind of adapt, and as we learn more, we figured it out, and I still haven't fully adapted back. I mean, my daughter's so young, she's still not even vaccinated. So, I still have to worry about this. So,
yeah, I mean, from then the early days of not knowing, and then now so many years later, now we're starting to learn more and more about who is most likely to have poor outcomes, and who's at greatest risk and so on. When did you first start to see this kind of metabolic syndrome, obesity, blood glucose, dysglycemia, and so on, that kind of emerging as a kind of a pattern?
It was very early on. I mean, in the beginning of the pandemic, we had no treatments. All we could do were our routine ICU care that we'd provide to anyone with respiratory failure. And the thing that was just different that struck me was that, it was someone that's, no different, like a 50-year-old person who happens to be just a little overweight or just have mild diabetes and maybe also is on one blood pressure medicine. It wasn't someone that was out of control diabetes or super, super, super obese, although we also had those too. But it was just having a couple of these mild risk factors really increased the risk to end up in my ICU. And so that's when we asked the question in our first study, is this happening in New Orleans? Is this just something that we're seeing here in New Orleans, right? And so that was the first determination. Is this relevant? And we were able to show that difference, and that people with metabolic syndrome tended to get the severe forms of COVID-19 more often. They ended up on a ventilator more often, almost 4 times more often.
Wow. And
they died more often. And this didn't matter how old they were. It didn't matter what other comorbidities they had. It didn't matter what sex or gender or ethnicity or race they were. And so that was only in a few hundred people here in New Orleans. And so, maybe that was something unique to our population. We're not the healthiest city, even if we know how to have a good time. But that is something that we weren't sure. So then that led us to let's see if we can figure out what's happening around the world. And so that's when we teamed up with some other organizations, and we're able to become part of a network to collect data from all across the country and really all around the world. There's only over 280 sites that we were able to get data from, and looked at hundreds of thousands of patients. And we asked the same question, right? If you have one of these 4 conditions, right? We kind of narrowed it down a little bit for simplicity. If you have pre-diabetes or diabetes, you have a history of high blood pressure, you have a history of abnormal cholesterol, or you are even obese or mildly obese, right? We showed the same thing, basically, that if you have any of those factors, the more you have, the worse you do. So if you have 3 or more of those, you have an increased risk for dying, for developing a respiratory failure from COVID. And then what was surprising in that study was not only is if you have the full-on metabolic syndrome, but for each one of those factors, your risk goes up for developing respiratory failure. And that's what really is, I think, most interesting. It's not a one and done, you have it or you don't. It tends to be a cumulative risk for each of these mild, seemingly mild risk factors. It increases your risk. And that's what we're trying to really get into right now.
So you mentioned the four factors: high blood pressure, uh, glucose, higher glucose, and so on, obesity, and so on. Are they all weighted equally, or is like obesity the greater factor, or the greater driver, or is one a greater driver than the other?
It's funny you ask that. They don't. I wouldn't say that one is a clear outlier. I wouldn't say that one is far and above the biggest risk factor. Ironically, obesity, for example, has been looked at in non-COVID ARDS before, and there's studies that show that obesity increases the risk for developing ARDS without COVID. This is years ago, right, in 2005, right? That they increase the risk of developing this inflammatory lung condition that people develop. What's surprising is that even though they have more chance of getting that disease, they tend to die less often. And so there's something called the obesity paradox, where it is seen with stroke and other conditions, and there's thoughts about why that may be, but it's present in ARDS too. And so what we see in COVID is not necessarily that case. I mean, we're still trying to figure that out exactly, but it definitely increases your risk for disease. But in COVID, it seems that you tend to die more often than in non-COVID ARDS. But there's definitely something about obesity where, my theory is more that the more obese you are, the higher risk you are from getting the disease. But often those tend to be younger patients, right? The older you get, the less obese. It's really that middle age range where you reach your peak obesity, let's say. And so I think the reason I think they die less often is they're younger and able to survive it. And we're not sure on that yet. The risk from diabetes is definitely there. And then honestly, cholesterol and abnormal cholesterol measurements really haven't been looked at as in depth as you would think. It's there's an extreme lack of investigation into that area. And then the similar aspect for high blood pressure. So, I wouldn't say one is a clear outlier. If anything is driving this, it's probably the combination of obesity and diabetes and something about that combination.
Well, so when a patient comes into the ICU, you have a pretty good sense of their trajectory then.
Yeah, sadly, I do, especially if they're unvaccinated. I mean, I have someone right now, same situation. The more of these risk factors you have, and a lot of people don't know they have this risk factor, right? I mean, I don't know about you, but a lot of people's, their BMI is either right below the cutoff, it's in that range of being overweight. I mean, 30 to 40% of our country is overweight or obese. That's, almost 1 in 2 people, and, they don't really know it. And even though they may have that status of being overweight, they haven't seen a doctor, let's say, for 2 or 3 years, and their A1C or hemoglobin A1C may be in the pre-diabetic range. And so you take these two seemingly mild risk factors, but actually what our data shows that although they seem mild, those are your biggest risk for getting sick from COVID. It's not having cancer, it's not having lung disease, it's these seemingly mild risk factors.
Wow. So then, are there potential ways, if you know who's going to have a bad outcome, are there ways of maybe kind of treating these individuals differently, or giving them other therapies, or kind of maybe more, I would say, like more of a precision medicine approach to kind of treating these people?
That's my hypothesis. I think, and I'll give an example without saying too much. We have some data that shows that there may be some certain biomarkers that can be used to identify these groups of patients. You may not need the biomarkers if we can prove that these clinical associations are enough to identify them. But let's say we can combine them with some biomarkers. There's a drug that's been studied for COVID, a type of drug that targets a certain inflammatory marker in the body. And they've finally shown that does seem to improve outcomes for COVID-19. Now, that drug it's not a miracle drug. All right, I don't work for the pharmaceutical company, and so I'm definitely not either way going to say, but I wouldn't say that is a miracle drug. I've given it to plenty of people, and I think it helps, but it isn't helping everyone in the same way. But that drug targets a part of the inflammatory system, which is increased in patients with metabolic syndrome. We know that. And so, I think you could easily make a hypothesis that perhaps if we can use this phenotype, I guess, if you want to say a phenotype, meaning a certain type of patient for a certain drug to target that patient. The problem is you have to do the research to show that before you can convince someone that we need to target them, and you don't want to just willy-nilly kind of hand this out to that patient and this one to that one, because that's just not following the best evidence. But my theory is I think we can use this connection that we've described to try to target our treatments in the ICU, and maybe other diseases too. Maybe it's not specific to COVID. Maybe it could be related to other inflammatory diseases that we see in the ICU.
Yeah. I mean, I think you mentioned too, in your papers that metabolic syndrome is an inflammatory condition. The respiratory failure is an inflammatory condition. COVID is inflammatory. So you think then this kind of therapy, say, assuming we get beyond the COVID pandemic, and do you have these learnings from what kinds of therapies might prevent or treat this condition? How would that be used beyond the pandemic?
Yeah, I think that's a great question. I think that's what I'm thinking, right? And so I think we're using COVID-19 as kind of a launching point to show this association. And I think if it does prove to work in COVID-19, I think it could be easily adapted to other types of critical illness. That's one of the biggest criticisms for research in the ICU is the research in the ICU is a little bit too, the patients are very heterogeneous, meaning that you have, let's say, all right, let me give an example. All right, so I have a 20-year-old patient in the ICU with respiratory failure, and he has cancer, let's say. And then I have a 60-year-old patient who is in respiratory failure, and he doesn't have cancer. He's pretty healthy, except he has diabetes. Should we be treating those people exactly the same? And that question is probably no, right? That 20-year-old person with cancer is probably honestly at a greater risk from dying than that 60-year-old person without cancer and just diabetes, and that we should probably be offering those people different therapies. Unfortunately, our research in critical care hasn't gotten to that point that we can identify who is going to respond to which therapy. And so what I want to use this metabolic syndrome, and really not just the definition of it, but really a metabolically unhealthy type of person, to see if that patient who may do better or worse with different diseases. And so beyond COVID-19, I think this may have application for other diseases as well.
That's so interesting. When we think of researchers, we think of people in lab coats and test tubes and research and so on, but you're doing research in the ICU. That's an interesting kind of concept to kind of do that. And you've published some very nice papers as well from that. So it's very interesting. How do you, for example, you talk about biomarkers. Explain about biomarkers. How would you collect them? How would you use them? What's the approach there?
It's funny you asked that, make that point. I'm giving a talk today, actually, to some colleagues here at my university. And the title of the talk is Science in the ICU, from care delivery to patient outcomes. And so, and part of what I want to talk about is really just how rich of an environment the ICU is for data. My job is nothing more than it's being a computer and taking a lot of data in and trying to weed out what's not important and focus in on what's important. And the ICU has so much data to study, whether it be clinical data or not, or biologic data, right? Because we have the sickest of the sick. And so we have plenty of patients that are looking for some form of hope. So biomarkers, you asked specifically about biomarkers, biomarkers is kind of a generic term, right? Something in your blood or spit or urine or something related to a laboratory measurement that we can then use, say it's high or low or not changed, and see if that can help tell us what to do in giving medicine and treating people. And I think that, ways that we can do this in the ICU is we can, for example, we could ideally, in an ideal world, I would say we measure blood when somebody gets admitted to the ICU. We see this biomarker, let's say marker X is elevated in that person. And we know from other data that marker means that this patient is going to do poorly. However, if that marker is high and we treat them at time point Y, then we're going to be able to improve that patient from doing poorly and actually recover. That would be the simplest way of putting it, and that we can find some set of markers that will allow us to treat someone in a unique way compared to other ways. The terms that we sometimes use for this are enrichment, right? So we're enriching a patient for either prediction or prognosis. So we can identify people, whether we can predict how badly they're going to do or how well they're going to do, and maybe we can change the course of that illness.
Definitely. That's so, and when I think of, from the other side of family, when you have a family member in the ICU and you just so much want to have the best care for that individual and, all the knowledge and all the best tools and so on. So I would imagine, things like biomarkers and better able to predict the disease course means that you can choose the best therapy, the best approach, and so not waste time on non-effective therapies and go straight to the approaches that might have the best outcome.
Right. That's one of the problems with, I think everyone that is trying to do research is usually trying to do the best to learn something new, to try to discover something. And the same with doctors, they're trying to get the patients better. I do believe everyone's doing the best they can. Sometimes I think when you think about translational research, right? Classically, we say, okay, we're going to look at a cell, an animal, a cell culture, whatever it is, and we're going to see how we can translate that to a patient. And I like to view the type of research I do in the ICU as more of a reverse translation, where I have these observations in the ICU. How can I relate that back to the bench? And I can take what I'm seeing and work with scientists to figure out biomarkers and ways that we can improve that patient. And I don't know that there's a right or wrong way. It's just, that's what I'm really more of a clinician or a physician first. And science for me is the fun part of the job. And if I can take that and collaborate with other members of my team, that's what I'm trying to do. And so it definitely is a way of taking advantage of the ICU from a research standpoint.
Seems like great. I mean, with capturing all that information and knowledge in the intensive care unit, collecting patient samples, creating information to better understand risk factors, and so hugely important for people. And when you think about it, you think about even saving lives. You think about saving lives of people with diabetes, but saving lives of people with metabolic syndrome. Even before you get diabetes, people are at risk. Right. And that's quite shocking. And then also too, I mean, what, a third, or is it like third of the people in the States have metabolic syndrome?
Oh yeah. Yeah. I mean, I think the numbers were and I just checked it recently, because over the past 2 years, since I think I first was writing a proposal for the ADA, that number's increased by 2%, and it's just, this is per the CDC's data. The number in Louisiana, I believe, was 38% or something of that nature. I mean, it was either obesity or metabolic syndrome, but it's in the range of 20 to 50%. So that's 1 in every 3 people have these constellation, and they just don't know it, or they do know it. And that's just what we can estimate. Yeah. And it's higher because so many people aren't seeking care. Look, I'm as guilty as anyone else,
Wow. So kind of in a sense, the knowing that metabolic syndrome is such a high risk factor, this must be a strong message to people to kind of reduce their risk factors, and exercise and diet and lifestyle and so on. So on one side, and then you have also too the potential for, if your person finds themselves in a situation like that, ideally to have biomarkers or better ideas around therapies to treat them. So, but it seems to me that you don't want to get into the ICU. So what would be the best way to avoid metabolic syndrome?
Well, I mean, I think, we all know what we need to do, and I'm just as guilty as anybody with doing the things that we're not supposed to do. Right. The key answer is what I would tell my son, everything in moderation. Right. And the metabolic syndrome results from inactivity and overfeeding, and so anything in excess, right, is going to be harmful. And the best way that we can really counsel people is to try to do things in moderation. And if you've already gone beyond that, to really try to cut back on certain areas, increase your amount of exercise, exercise every day. I know we talk about doing it, but here we are sitting in chairs, not doing it, right? We need to really adopt this as a culture of maybe we should have all our desks be standing, and we should always be walking, or maybe it should be implemented as part of general society. I lived abroad for a bit of time, and in Japan, actually, I remember as part of their work, they had an hour where they had stretching as part of the day, right? That was just part of like the work day for the whole company, I remember. It's just something that maybe we should be more systematic about applying to our society. I think we've become just fast food is easy and it's cheap. And I think it's unfortunately, I think it affects those that need it the most. And so there is definitely some disparity, I think, in socioeconomic status as well. And we have some studies that show that too. And if you really look at the data that we've presented, you'll see that there are certain populations that seem to suffer more from metabolic syndrome. And I think it has to do a lot with socioeconomic disparities and health disparities. So it's something else that I think we can work to improve. So
yeah, it's an area that ADA is very interested in as well. The health disparities, and the COVID pandemic kind of laid bare the health disparities in this country. And the disproportionate amount of COVID-19 and people of lower socioeconomic status. So that's really challenging. So, but yeah, I know we're coming up close on time. One last question I'd like to ask is about vaccination. So, we hear about, obviously we know that vaccinations dramatically reduce the risk of death dramatically. So there's no question about it, and everybody should be taking vaccinations and boosters and so on. But there are breakthroughs, the breakthrough cases and low level. Have you seen anything in terms of metabolic syndrome? If a person, is there equivalent level of protection or what's the idea there?
That's a great question. It's something I've also wondered myself, right? We were able to show this risk clearly in an unvaccinated population. Does this exist in a vaccinated population? I don't have the data at all to answer that question. We can get that data. And I'd be curious to know the answer. I don't know the answer. I can tell you anecdotally in my own experience that, yes, there definitely seems to be some increased risk with metabolic syndrome. However, the vaccines are so effective that I think that the immune response seems to be good in that patient population, that I don't think it's an overwhelming association. Meaning, I think, yes, metabolic syndrome increases your risk from severe COVID-19, whether or not you're vaccinated. But I don't think that the vaccines are not working for those patients. I think they're still working, bottom line. And that's completely anecdotal off of working in the ICU. I don't have the data yet to support that hypothesis, but I feel confident in that. I have family that have, metabolic disorders and diabetes, and I feel confident that the vaccine is going to work for, my mom and other people. So that's my best answer.
Yeah. I mean, I think absolutely so critical for everybody to be vaccinated, and boosters too is so important. I mean, we're seeing that the boosters are making all the difference as well in terms of protection, and so that's good to know. So this has been great. Really enjoyed chatting with you. This is so informative, and really, it's a pleasure to be able to, that ADA is able to fund you for such excellent, important research, and really appreciate everything you're doing for people with diabetes.
Yeah, no,
and metabolic syndrome, and pre-diabetes.
All of it. I think the ADA is really, in my mind, has really motivated me to continue to explore this, and has really helped learn new information to try to help people. And so I hope it does help people, especially that 1/3 of the population that's suffering from these diseases. So thank you again.
Definitely. Well, thanks so much. Really appreciate your time. All the best.
All right.
Good. Bye-bye.